following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, good health after 60. Two experts are here to answer your questions. Now here's your host, Dr. Joe Perdome.
Good evening. Do you feel as good now as you did at 40 or 50? You may be able to feel as good as you did by picking up a few new healthy habits. What should you be eating? Is it too late to become active? What are some of the medical tests you should get on a regular basis after turning 60? We'll get the answers to those questions and more tonight from our two guests. Dr. Rick Lane, a WVU internal medicine physician specializing in geriatrics, and Dr. Richard Ham, also a WVU specialist in geriatric medicine and psychiatry. If you'd like to ask our guests a question, please give us a call. Our phone lines are open now. Rick, what are some of the most common medical problems that people face as they turn 60?
Well, after the age of 60, people have sort of some of the same problems that a lot of people younger have, including hypertension, hypercholesterolemia, increasingly diabetes, heart disease, and so forth. And in geriatrics, of course, we see patients from roughly 65 to 105. And the older age group within that, the so-called old, age roughly 85 plus, tend to have those problems, but also other problems, the so-called geriatric giants, where these are things like failure to thrive, which is unexplained weight loss, dementia, memory problems.
All right, let's talk a little bit about dementia because I'm not quite 60 yet, but I may already be getting there. I want to learn a little bit about dementia as we age. Tell me, is there anything we can do to prevent it?
There's a great deal we could do to prevent it. Good cardiovascular health, avoiding being overweight and the risk of diabetes, which is a risk factor for developing dementia. Maintaining an active, involved lifestyle, not just physically but mentally, developing habits that will keep you intellectually stimulated later in life, like reading, no passive things, active things that engage the mind. Those are actually factors that have been associated with postponing memory change and possibly slowing dementia even after it strikes.
How much of it is lifestyle versus genetics? Do we understand that at all?
It's partly genetic, and I'm afraid a lot of our experience in old age is genetically predetermined. We can't control everything, but there's a great deal one can do to reduce the chances of many of the chronic depressing aspects of old age by paying attention to health earlier in life. I should have mentioned avoiding accidents, avoiding actually head injury, both very early in life, I mean in the 20s or so, maybe something that's going to be a problem to veterans and explosions and so forth, but also later. Head injury is a precipitant of the tendency to get what most people would call dementia, progressive loss of memory and so forth in old age.
Okay, Rick, so I haven't been good, like Richard's telling me to, but I want to reverse the trend. I asked you before the show, how do you teach your patients to get back in shape, and you said exercise, and I asked for more specifics, and you said just do it. But give us a little bit more specifics. I want to start exercising. I'm 65. I'm a little bit out of shape. Haven't done it in a long time. What do I need to get checked first, and how do you start gradually so you don't mess up?
Sure. I would probably begin by asking you what you are doing, and what has been your activity level. So to get an idea of what you're capable of doing. And some of our patients aren't able to ambulate, they're not able to walk. There's still some chair exercises they might do. But if I assume you're ambulating, walking, then I would have you on a walking program to start. And the general rule in geriatrics with regard to exercise, with regard to medication therapy, is start low and go slow, but go. So probably the most important thing is to pick an exercise you will do. There's the key. That's the hard part. What will you actually do day after day after day? To have a routine so that you're doing it every day. And I always tell my patients, you really need to decide what part of the day are you going to be doing this. If you don't pick a time and develop a routine, it's not going to happen. So pick something you can do. For example, if you love to swim but you can't get to a pool, well, swimming's not going to be your exercise. Something you can do, something you will do, have a routine, start it, just do it.
And I know at any age that the carrying on an exercise program is critically important to have a partner so that you kind of feel guilty if you don't go and you leave them standing. So that's always what I felt was a really important facet. And I think having a close friend that you exercise with is also good to help prevent the dementia, the depression, the memory loss, to have somebody to converse with and to stay active.
You need somebody to keep up your will to do these things. It's all very well to associate, as we do, learning to play a musical instrument, reading a lot, playing strategic games. These are various, like bridge and chess. These are things that have been associated with, again, postponing memory loss. But you need somebody else to motivate you to do those things, somebody to stimulate you to do them. I spend actually a long time with my patients talking about reading. It seems to me one of the obvious, and it's at the top of the few studies that have been done of the activities that have some real chance of postponing decline even when it's taking place. It's the right exercise for the brain, just as we're talking about exercise for the body.
Brain exercise, good thought. Well, we have somebody on the phone way here, Shirley from Ohio County. Shirley, ask us your question, please.
Yes, I am having trouble with tightness in my ankles, around my feet, but there's not swelling. And I do have some numbness in my legs. I mean, it feels like numb, but you can feel it, it really isn't numb. But it is bothering my walking. And my blood pressure, usually when the doctor checks it, it's pretty good. And there is no swelling. But I am having difficulty. It bothers me walking. But I have had some sinus problems. Whether that is bothering the walking, I don't know.
Shirley, how many years young are you? You didn't mention.
I'm 88.
88. And what's your general weight? Are you?
Right now, I'm 174.
Okay. Anything else you want to know before you answer, Shirley?
Yeah, wondered how long it's been going on.
It's been going on for quite a while. I'll say a few months.
A few months. And is this feeling out to the toes and into the up to the feet and ankles?
Not to the toes. It's mostly around the ankles, around the heel.
And does it bother you more when you're resting with your feet up at nighttime or when you're walking?
When my feet's up, it seems like it's not as bad. It is still there, but it's not as bad.
Okay.
I sit with my feet up.
It may be to do with some venous stasis there, but I think you and I can think of a few medical things that will be rule outs, but they probably are going to be able to be ruled out by a good physician, and you'd end up most likely talking about some kind of activity to really help keep moving despite these symptoms. I mean, it seems to me the biggest harm here would be for it to inhibit her from moving around at all. I mean, that's the harm. Whatever the underlying cause, but there are a few things I guess I would want to check for, like blood glucose, B12 and things like that.
Yeah, I think here the examination is really important.
Sure.
There may be something that the physician might pick up on that she's not seeing herself. Of course, we'd wonder about the big distinction between, is this musculoskeletal arthritis, or is it nerve, is it a neuropathy, or is it circulation, is it a vascular problem?
Sure.
And I'm sure she should see her personal physician for a good examination.
Absolutely.
I totally agree, Shirley. We wish you good luck, and I think your family doctor ought to be able to pick which one of those 3 workups would be most appropriate for you, but you need a good physical exam to know which direction to start. Would encourage you to do that, though, and stay active. Thanks for calling. Our next caller is Jean from Marshall County. Jean, what's your question for us tonight?
Yes, I'm a massage therapist, and I work with some geriatric patients, including my parents, and they seem to get a lot of benefits from it. I'm wondering what your guests think of massage and other hands-on therapies, especially in the failure to thrive patients, and what they know about that.
That's interesting. Rick, you mentioned failure to thrive. I mean,
Yeah, that is a very interesting question. I think massage is, in my mind, massage therapy is sort of in the stage that acupuncture was a few years ago. Acupuncture, there seemed to be something to it. Unfortunately, we didn't have a lot of studies to support it, and then more and more that's come along and shown that there is a real effect there. And massage therapy, I think, also is in that sort of stage. I saw an article just the other day about the efficacy, the effectiveness of massage therapy for chronic low back pain, which is interesting, and as you know, is a tremendous challenge to treat. So I'd have to say, with regard to failure to thrive, I've not seen any literature on that, but I'm sure somewhere someone's studying it.
well, thanks for the question, Gene. That's a good question. I know that doctors don't touch our patients quite as much as we used to, and that's something that patients miss, I think, and it conveys a little bit more of a sense of engagement. And I think that massage therapists and physical therapists still do that maybe a bit better than we doctors do sometimes.
I think in particular that we worry a great deal about pain relief, and this is the state with the oxycodone problem. And certainly, for when you think of how many pains that have been studied a lot, like back pain, we really don't quite know, but there's more than a few hints that it is actually somewhat connected with muscular spasm, and relaxing those. I don't know enough about massage therapy, but I would imagine it's relaxing to those muscles, and it can massage their circulation back some. I can think of a lot of advantages to it. It needs to be studied, though, doesn't it? And
quite.
there's more logic going for it than there was originally for acupuncture, and we know that works.
Let's see what Pat from Raleigh County has to ask us tonight. Pat, you're on. What's your question, please? Pat, are you there?
And then after they burn for a while, they would feel like they're ice cold.
Pat,
And
we missed.
and now, excuse me,
sorry.
now my feet hurt all the time, even up past my ankles. And I didn't know if maybe it's neuropathy or what it would be.
You know, Pat, you got the very first part of your question got cut off. So tell us just the very first thing you said. I missed it.
Oh, okay. Probably about 2 years ago, my feet started feeling like they were ice cold for hours,
Okay.
and then all of a sudden they would start burning, and they'd burn the rest of the night. And now my feet hurt all the time, and sometimes even like under my toenails, they just sob.
Okay. And tell us approximately how old you are, Pat?
I'm 67.
Do you have diabetes?
Not that I know of. I've been checked, and they say I don't.
And are you? What's your approximate weight?
173.
Anything else you want to ask, Rick?
I don't think so. Yeah, that's very relevant to ask about diabetes.
Yes, diabetes absolutely at the top. I'm a little concerned about her circulation, whether it's related to exercise, whether movement makes it worse or better. But it's rather like our other leg pain issue. It really needs to have a medical workup of the right kind. It does sound rather vascular, but that we're skating in the dark here until we get the person seen.
The one point she made that I think is quite interesting is the issue about diabetes. And of course, we would think of diabetes as one of the number one, maybe I suppose the number one cause of peripheral neuropathy, which her symptoms sound a bit like. And a blood sugar test, a single blood sugar test, wouldn't rule that out necessarily. And it has been the case that the full-fledged diabetes develops later on into this course of neuropathy. And it's an interesting phenomenon. I don't think completely understood.
Well, Pat, thanks for the question. We recommend that you get a checkup with your doctor and have them check your circulation and perhaps your blood sugar for diabetes. Those would be the two things that all three of us immediately thought of. And so thanks for that. Those would be the two most common reasons, and we wish you luck. I think that diabetes has got to be much more common in West Virginia than it is in a lot of other places. It seems to be a particularly endemic problem for our state. Is that correct?
Right. And of course, type 2 diabetes, the common type of diabetes for adults, not the exclusive, but the common type of diabetes for adults is so linked to obesity, very tightly linked to obesity. And unfortunately, West Virginia has one of the highest probably top 2 highest rates of obesity in the country. So there again, among the many virtues of exercise and good diet is trying to get this obesity epidemic and diabetes epidemic under control.
I think that's an important message to get out there. I mean, if you are overweight and you have type 2 or adult onset diabetes and lose weight, you can actually reverse some of the side effects of the diabetes. I mean, you can help your blood sugar, right?
Right, absolutely. And the thing I will say, it's a little bit, perhaps a little bit harsh, but I will say this, in geriatrics, and again, we see people 65 plus, and we see many people in their 80s and 90s and a few in the early 100s. We don't see many people with obesity. And the reason for that is those who were obese didn't get that old.
Wow.
And I actually allied to that is the fact that I empathize with the fact that somebody who is overweight and it's uncomfortable to move around, it's more comfortable to stay sitting still. All of us know the consequences really of immobility, but it's a vicious cycle. It's very difficult to get out of a fixed routine habit where someone's overweight. This afternoon I was with a patient and it's been a problem for years for this person. As she gets more immobile, more uncomfortable, in fact, she's gaining weight, and the whole thing's a vicious cycle. It needs somebody outside often to get things motivated and moving, and it's often been pointed out that the extremely obese people, the ones who get into the record books, someone's bringing them their food. Somebody else is there helping them to maintain that. And it really needs looking beyond the patient, in my opinion, for those chronically very overweight people. I don't have a magic answer because it's definitely a struggle. But it's a struggle worth making because the relationship of overweight to diabetes and of diabetes to these vascular things that we immediately think of when people are telling us about painful feet and pain is so strong, and lately as a risk factor actually for dementia as well. It's a very vicious thing, actually, being obese. It leads to tremendous problems, and we really should be fighting it at every level.
We're talking a lot about the things that you get, the negative part of it, and part of the thrust of the show tonight was to encourage people, that they could get back in good health after 60. And I will say, as an orthopedic surgeon, I do have patients, occasionally make me very, very, very happy who come in and they lose 30, 40 pounds. Mm-hmm. And those patients, their knee arthritis feels better. They've shown if you lose as little as 20 pounds, even if you weigh 400, your knees really, stop hurting in many people. So it doesn't take a lot to make a big improvement.
I think that's important to say. I mean, the studies show, don't they, that the people who need exercise most are the ones who exercise least. And wasn't there that one about getting rid of the TV remote and the vast difference it made to actual measurable parameters of fitness in somebody who was otherwise immobile? You could make out quite a good argument in favor of taking, little steps first.
Right.
They'll make a big difference.
Let's see what Fred has for us tonight. Fred from Kentucky, you have a question for us. Please go ahead.
Yes, I have spinal stenosis, and it seems to be that nobody seems to know what to do anything about it. It's very uncommon from what I can understand, and it seems to be getting worse. And I just wanted to know if y'all knew anybody I could see, or you could give me some information on it.
Have you had physical therapy for that?
Yes, but it when I tried, it hurt so bad that I can't go more than 1 or 2 times a week.
Fred, what's your age and how long have you been bothered by this condition?
My age is 74, and I've been about 4 or 5 years now.
So spinal stenosis is a treatable condition in many people when we try and treat it non-operatively initially, and I'm sure you gentlemen do see a fair bit of it. It's not that uncommon. And there are surgeries for people who fail medical treatment where we actually go and open up your spinal canal and give more space to the spinal cord and nerve roots that are being squeezed, which is what causes the problem. So if you've seen somebody about it and you've tried physical therapy, a spine surgeon, either an orthopedic or a neurosurgical spine surgeon, would be somebody who you might want to talk with, because that is, as long as you're healthy enough to have surgery, a treatable condition in many cases, even if the conservative management's failed. So visit with your doctor and ask him if he thinks maybe it would be appropriate to send you to a spine surgeon. And good luck, Fred. I think don't give up on that. There are some answers for that.
The other thing I might just add is, of course, he's told us what his diagnosis is, and that he's tried conservative therapy. And so now there are two possibilities. It is that diagnosis, and conservative therapy didn't work. And as you say, it's time to get on to a spine surgeon. Or maybe it's not that diagnosis, or maybe it's not only that diagnosis. And the fact that he had pain with physical therapy makes me think maybe perhaps rethinking that part of it.
Mm-hmm. Mm-hmm.
That's a really good point, that the diagnosis may or may not be correct. Well, Fred, good luck with that. I would definitely look back into that, though, and don't give up on it, because that sounds like it should be something treatable, and we wish you good luck. Our next call is from Sue in Ohio County. Sue, what's your question tonight?
Hi, I have a problem with swollen feet and legs. I have a neuropathy, and this swelling has been since about 6 months, and I've gone to the heart doctor. They checked me out fine, and I've had all kind of tests. Yesterday I had a venous reflux test. I haven't heard from that yet, but it makes me very debilitated. I have another problem along with it also. They diagnosed me with Charcot-Marie-Tooth about 10 years ago, but that's eliminated because I had the blood work. So we're not real sure. They say it's a genetic neuropathy that I have.
So you didn't mention your age?
I'm 73, sorry.
73. Any other questions for Sue, gentlemen, to get started on that?
I'd kind of like to know if anything's relieved this yet. I don't quite know when it gets bad. It's obviously a bad pain, and I'm sorry that it's so rotten for you. And I'm glad someone's looking into the venous return. Anyone who mentions swollen legs, I'm thinking that the first thing I look at is does the person actually get a good heel-toe movement when they walk around? And are they getting some exercise, or are they sitting like we all are at the moment with our legs down and immobilized? But there's more to it than that. She's obviously right in the middle of some investigation. It's difficult to comment, actually, when that's one possibility, is that it is indeed poor venous return. But there's so many different things that can be going on in someone's legs. We seem to have had 3 different people with problems with their lower limbs, and the fact is, vascular, neuropathic, musculoskeletal can all contribute, and somebody general enough to really be broad in their consideration needs to have a think about it.
Mm-hmm. And I'm not sure how much of the pain is from the neuropathy and how much of it's from the swelling itself.
Exactly. Well, and we see this, don't we, with somebody who has any pre-existing neuropathy, and the medication makes their legs swell, or they're immobilized for some reason, and something adds to it.
Well, I like your idea also about gait alteration, because if they don't get a good pump out of their calf muscle, then they don't get good return against gravity, and that could also be, I like that idea.
Yeah, I do tend to think of what the consequences are of this symptom that really are going to get you into trouble in a few years, and they would include that.
Well, Sue, good luck with that. You definitely should keep on with the testing. It sounds a little bit complicated, and we wish you good luck. We got one more quick call. Let's do Helen from Raleigh County. We have got a couple of minutes left. Helen, what's your question for us tonight? Go ahead, please.
I want to know if you think it's necessary to have a colonoscopy every year, one time a year.
Colonoscopy every year. Helen, how old are you?
Can you hear it?
Helen?
85.
85. Okay. Does Helen need a colonoscopy every year, gentlemen?
Well, no is a simple answer, but unless there's some special reason that's being followed up and that's been recommended.
Yeah.
How often, Rick?
Well, if she doesn't have any underlying disease that's being followed up, then the argument would be made for no colonoscopy after the age of, it's arguable depending on which specialty society you read, but some would say after the age of 80, no more colonoscopies. As you know, colon cancer, which is what we're screening for with colonoscopy in the normal person, is a very well understood disease which almost always has a very slow pattern of growth from no disease to adenomatous changes, which aren't cancer, to cancerous changes. And it is a slow process over a number of years. So the only reason I can think of for an annual colonoscopy for some period of time would be someone with certain inflammatory bowel disease who are at very high risk of quick development of colon cancer.
Oh, well, good. Well, Helen, ask your doctor. Maybe you don't have to do that every year anymore. Maybe you get to graduate. Good luck to you. Thanks for the question. So we appreciate that. I did not know that. So she may be able to slow down the colonoscopies. Thank you for all the good calls tonight. We've been talking about good health after 60 with Dr. Richard Lane, Dr. Richard Ham. Thank you both for being with us. If you'd like more information, talk to your family doctor first or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. Joe Prudhomme. Good night and good health.
Join us again next time for another edition of Doctors on Call.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.